Today we're diving into something really fascinating, the incredible diagnostic power hidden inside the ventricular premature beat, or VPB. We're going to see how this incredibly common arrhythmia, which so often gets dismissed as just electrical noise, actually gives us this unique, almost magical window into the heart's activity, helping us solve some of the trickiest ECG puzzles out there.
So here's our game plan. We'll start with the central paradox of the VPB itself, how something disruptive can actually bring clarity. Then we'll jump into a really detailed clinical case of digitalis toxicity to see this in action. That case will set the stage for us to explore 4 major ways the VPB is a diagnostic superhero, revealing hidden P waves, exposing atrial flutter, telling P waves and U waves apart, and finally, proving a rate-dependent bundle branch block.
All right, let's kick things off with this core concept, which is a bit of a paradox. You see, a VPB, by its very nature, is an arrhythmia. It's an ectopic beat that messes up the normal rhythm. But here's the twist. Its diagnostic power doesn't come from the beat itself. Nope, it comes from the silence it creates afterward, that full compensatory pause. That pause gives us a clean, undisturbed baseline that lets us see what's really going on electrically.
And that really is the big question we're tackling today. How on earth can a moment of electrical chaos give us such a profound window of diagnostic clarity? Well, to answer that, there's no better way than to walk through a real-life case study that shows this principle off perfectly.
So let's turn to our patient. He has a history of alcoholic cardiomyopathy and comes in with decompensated congestive heart failure. This case is just a fantastic, step-by-step example of how a single, seemingly random VPB can kick off a whole diagnostic chain reaction. Let's look at how he presented. Strip A shows a regular wide complex tachycardia clocking in around 120 beats per minute. Now, the wide QRS makes sense with his known bundle branch block, but we can't see any P waves. So what is it? Sinus tach with aberrancy? Atrial tach? VTach? It's wide open. But then, the first clue appears in strips B and C. See that VPB? And look closer. See that little notch, that subtle blip in the ST segment of that beat. That is a huge hint that there's some atrial activity hiding in there.
Okay, so after some initial treatment, the rate slows down to 85 in strip D. And this looks deceptively like a simple sinus rhythm with a first-degree AV block. But it's a trap. It's the VPB in strip E that blows the case wide open. Look at the ST segment of that VPB. You can see a clear deformity there. What is that? It's a non-conducted P wave that was totally buried in the T wave of all the other beats. And that, my friends, unmasks the true rhythm. Paroxysmal atrial tachycardia with a 2-to-1 AV block, a classic textbook sign of digitalis toxicity.
As we move on to strips F through H, the diagnosis just gets stronger and stronger. Strip F gives us an even clearer look at that non-conducted P wave. Then in G and H, we start to see AV Wenckebach. So now you've got this whole picture, atrial tachycardia with a variable block, which is undeniable proof of digitoxicity. And because of this evidence, all unmasked by a VPB, they correctly held the digitalis, which likely prevented a much worse outcome.
So let's fast forward 2 days later to strip I. The tracing looks great, seems like normal sinus rhythm, but how can we be absolutely certain? What if it's actually an atrial tachycardia that's now conducting 1-to-1? Well, once again, a VPB gives us the final, definitive proof. Look at the ST segment of this new VPB. It's perfectly smooth. There's no notch, no deformity, nothing. That confirms that the underlying ectopic atrial activity is gone. The patient is truly back in sinus rhythm, and the digitalis toxicity has resolved.
So, this case is the perfect launching point for our first general principle. Using that beautiful compensatory pause from a VPB to find P waves that are hiding, whether they're buried inside a T wave or lost in a wide QRS complex.
All right, check out this 12-lead ECG. We've got a narrow complex tachycardia around 105, but where are the P waves? They're nowhere to be seen, so we're not sure what the rhythm is. Now draw your eyes down to the lead 2 rhythm strip at the bottom. See that VPB? The long pause after it gives us this perfect, clean, isoelectric baseline. And what pops out? A crystal clear sinus P wave. And just like that, the mystery is solved. This is sinus tachycardia with a first-degree AV block. The P waves were just hiding in the T waves the whole time.
And this principle is incredibly versatile. It works for both narrow and wide complex tachycardias. On the left, you've got a narrow QRS, where it's tough to tell what those post-QRS bumps are. The VPB pause proves there's sinus P waves. Now, on the right, we have a much scarier situation, a wide QRS tachycardia that you'd be right to suspect is VTach. But again, look at the pause after the VPB.
It unmasked disassociated sinus P waves, proving this is actually a supraventricular rhythm with a bundle branch block. That's a huge, critical distinction to make.
Okay, let's move on to our next trick, unmasking atrial flutter. You're about to see how those classic flutter waves can be so well disguised by the QRS and T waves that they look like a totally different, more benign rhythm. That is, until a VPB comes along and reveals the truth.
So have a look at strip A. Your first interpretation here seems pretty simple, right? It's a regular rhythm at about 68, looks for all the world like sinus rhythm with a first-degree AV block. It's a very logical conclusion, and it's completely wrong.
Now get ready for the big reveal in strip B. The VPBs show up, create those compensatory pauses, and suddenly, bam, the true atrial activity is completely unveiled. You can now clearly see that classic, regular, sawtooth pattern of flutter waves marching along at 300 per minute. The VPB just exposed the deception, and we have our correct diagnosis: atrial flutter with a high-grade block.
And this brings up another critical role for the VPB. It can confirm if your treatment worked. In strip D, after treatment, the rhythm looks like it's back to sinus. So how do we prove it? Another VPB comes to the rescue. Look at the pause. The baseline is now flat, isoelectric. This confirms the flutter waves are totally gone, and the patient has successfully converted back to sinus rhythm.
All right, now we're going to tackle a much more subtle diagnostic problem, telling the difference between P waves and prominent U waves. You know, when you see that little deflection between the T wave and the next QRS, figuring out exactly what it is isn't just an academic game. It has huge clinical implications.
So this is the key question. Is that little bump a P wave? Is it a U wave? Or is it maybe both of them fused together? Just looking at the timing isn't always enough. So now we're going to use a VPB combined with a little multi-lead detective work to systematically solve this puzzle.
Let's dissect this ECG. First, focus on the lead 2 rhythm strip. Inside that long compensatory pause, you see a definite deflection. Now look at its timing. It's way too late after the VPB's T wave to be a U wave. It has to be the P wave. So boom, that confirms a first-degree AV block. Okay, step 1 is done. Now for step 2, let's look at lead V3. In this particular lead, the P wave happens to be isoelectric. It's flat. So that prominent positive bump you see after every T wave in V3, it can't be the P wave. By process of elimination, it must be a prominent U wave. And there you have it, the final diagnosis: sinus rhythm with both a first-degree AV block and prominent U waves.
And why is it so important to pick this apart? Because each of these findings points to different and very serious problems. Prominent U waves, that's a classic sign of severe hypokalemia. A first-degree AV block in someone with endocarditis, that could be a sign of a life-threatening paravalvular abscess. And what if we decided it was only U waves? That would suggest an accelerated junctional rhythm, making us worry about digitalis toxicity or ischemia. Getting this right matters.
Okay, for our final principle, we're going to see how a VPB can be the key to telling the difference between a permanent structural bundle branch block and one that's just functional, one that only shows up when the heart beats fast.
So this ECG clearly shows a left bundle branch block morphology. The question is this block always there, or is it a rate-related thing? The VPB gives us the answer. That long R to R interval from the compensatory pause gives the left bundle branch a little extra time to rest and recover from its refractory period. And what happens next? The following sinus beat conducts normally down both bundles, and we get a nice, narrow QRS. That moment of normalization is definitive proof that this is a rate-dependent LBB.
This really highlights the key differences, right? A rate-dependent block is functional. It's just a timing issue, a matter of refractory periods, and it'll go away if you give the heart a long enough pause. A permanent block, on the other hand, is usually structural, something pathological that's there no matter what the heart rate is. And telling these two apart is fundamental for thinking about prognosis and management.
So, if you take one thing away from our discussion today, let it be this: that compensatory pause after a VPB is not just noise. It is a moment of profound diagnostic clarity. It's a special, quiet window that gives you an unobstructed view of the heart's true underlying rhythm. And so I'll leave you with a question for your own clinical practice. The next time you see a VPB on an ECG, please don't just dismiss it. Stop for a second and ask yourself, what hidden information is this little beat trying to show me? What diagnostic puzzle is it about to solve?